what I'm going to basically talk about is very, very basic. As to first of all, I know we have gone through pathophysiology, but there was a lot of technology discussed, and lots of times what ends up happening is some of the terminologies are so complex that it becomes sometimes difficult to keep a track of it. Although my topic is to talk about mainly indications of ECMO in pediatrics, but I'll just try to simplify as much as possible. So we know that extracorporeal membrane oxygenation is a modification of conventional cardiopulmonary bypass, which has been happening for ages, on heart surgery. When you have an open heart surgery, you need some pump to circulate blood in the body, right? To the brain, to the kidney, to the vital organs, so that when the heart is being operated upon, the rest of the body functions are maintained. And here in ECMO, and then from the cardiac surgical point of view, when the patient is not able to come off that bypass machine, as the heart edema got better, contractility got better, and why the contractility got worse? Probably because of somebody operating upon the heart and having a bad systemic inflammatory response syndrome that happens as soon as you put somebody on a cardiopulmonary bypass, because just the physical circulatory problems, the RBCs break down, the platelets break down, and the body tends to respond to many of these cytokines, and there is a cytokine production. So this is basically like a big storm, physiological, pathophysiological storm that comes up, which needs to be managed, and you need time, okay? So what we are talking about right now is when you do a heart surgery, you need somebody to come off bypass and is not coming off bypass, and that gets extended for about 48 hours, 72 hours. So that's how it started. Then earlier we had talked about in 70s, Bob Bartlett in Michigan put some newborns on ECMO, and which we saw a picture of the survivor. I have the same picture too, the girl who celebrated her 21st birthday in 1996. After being on ECMO for meconium aspiration and severe PPHN, pulmonary hypertension. So that was the respiratory angle. And then, over the years, what ended up happening was that even at that time, there were many patients with ARDS. Warren Zapel in Mass General tried ECMO, and it just failed miserably. Mainly because we did not have much of experience, and maybe those patients were septic, maybe those patients were put on ECMO quite late. Then there was this resurgence from, Caesar trial, H1N1 pneumonia happening in Australia. People started thinking about that you've used prone positioning, high frequency ventilation, even nitric oxide, nothing is working, so let's try this. So ECMO was tried, and it showed results, and that's why, again, the resurgence of all of this technology. And by the way, the neonates, where it was really started, we got so much better at high frequency, conventional ventilation, sildenafil, nitric oxide, managing this pulmonary hypertension, that the ECMO went down. Okay, we didn't use ECMO as much. So now if you look at it, it's sort of come to a midway. Some newborns, very, very bad ones, but mainly very bad respiratory failure in adults. But our cardiac ECMO has continued at the same level wherever you may have a problem with the heart during surgery. But the new indication that has come up recently is ECPR. So you had a cardiac arrest, and you have a good system where you can put somebody on this machine within 15-20 minutes while the CPR is going on. It's been shown to be helpful. So the basic veno-venous and veno-arterial terms that are being used is vein is being used to take the blood out, warm, oxygenate, put it back in the vein, makes it VV, veno-venous. So it could be a one side femoral vein or the other side, or it could be internal jugular and put it back in femoral. So venous blood coming out, oxygenated, warmed, and put back. Veno-arterial, mainly where you have a cardiac dysfunction or a problem with cardiac output, so therefore you need the pump function of the machine also, along with warming, oxygenation. So that's why VA ECMO tends to be used more often on patients who have, let's say, bad cardiac failure, myocarditis, or the patients who have not been able to come off bypass after congenital heart surgery. Let's say if the patient had a cardiac arrest, then veno-venous ECMO will not work, that you'll have to use veno-arterial ECMO.